Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now. All right, welcome to another podcast. Of course, I am with the esteemed Dr. Jason Williams of the Williams Cancer Institute. Of course, part of the team as well, but we're going to be talking about a very much relevant in the news publication, actually research article that is super exciting in the arena of immuno-oncology. But Jason, you've been there. So it's almost like the party was developed by the Williams Cancer Institute, and it's just great to see others now joining the party.
Yeah. People are finally seeing, and of course, seeing that injecting the immunotherapy in the tumors is the way to go, and obviously with the CD40, CD40 is an amazing immunotherapy agent. I call it the Swiss Army knife of immunotherapy. I mean, it does like a little bit of everything.
Yeah.
I mean, it's almost like, what doesn't it do? I mean, it really has like such a bridging point between, generating the initial immune response and carrying it over. It has a lot of broad functions, and it's super important. So, this is a great agent, but one that has to be in the tumor, because if you give it systemically, you get all this off-target effect.
And of course, you can look in the show notes. The studies will be there. We encourage you to read them yourself. Don't take our word for it, but read them yourself. So I'm entitling this, Inject the Tumor, Ignite the Immune System. It's the power of intratumoral CD40 agonism. Go ahead, next slide. So, you kind of touched on it already, what CD40 is. It's kind of a master regulator. You called it the Swiss Army knife. I think that's actually a better term, Jason, because what's that, when you say Swiss Army knife, people have a picture.
Right.
When that comes to the immune system, what does that mean?
I mean, it's like it does a lot of things. Maybe it's not perfect on everything, but it makes a lot of things happen, and you can get a lot done with one tool, right? Whereas like other things are very specific, whereas this one has just so many things that it does. It's just kind of incredible, and that's why I think a Swiss Army knife seems like a good analogy.
Oh, I think that's a better one than master regulator, because when we talk about the master regulator or Swiss Army knife, it's because it's having multiple immune functions. I mean, it's priming the T cells, it's enhancing antigen presentation, it's really bridging the innate and the adaptive or humoral immunity. So now CD40, that's a drug, but it's a component of the immune system.
Yes, it's a receptor, and this is a CD40 agonist. So we're using a monoclonal antibody that binds to that receptor and stimulates the CD40, and so that's its role. And but it's amazing, all the things that's involved in, because you get activation of that receptor, and it turns that some of the innate immune response into a more adaptive immune response, and then also you've got even going on to recruitment of like natural killer cells and dendritic cells, all this other type of things with CD40. It's just it's so multi-purpose. So.
I mean, what you're describing there is the pieces of the puzzle, the team, if you will, that comes together that gives us the abscopal effect.
Yeah, I mean, for us, and that's what, like when our therapy, like our SYNC-T therapy, we have CD40 and that, and and CD40 is like your base. I mean, that's the one where you just have to have it, and if you only got one thing, that's what you got. But you need other things to make it work better. But that definitely is like, the real linchpin. That's like the key component.
So I want to go through a timeline, and we'll get into this particular study where they only used a CD40 monoclonal antibody, because I want to insert you and the work that you pioneered at the Williams Cancer Institute into this timeline, because in the 1990s, CD40 was first discovered as a master regulator or a major contributor, Swiss Army knife, to antigen presenting cells. But then in early 2000s, what we saw is that initially it was really activating and enhancing the innate immunity, cytotoxic T lymphocytes, antigen presentation, leading to tumor regression in mice. And then You've mentioned Vanderhyde
Yeah.
quite a bit. Elaborate on
Yeah.
that, because that really brought it to the public consciousness in the scientific arena.
Yeah. Robert von Hood at UPenn, did a lot of studies looking at pancreatic cancer, and he was doing systemic CD40 with with combination with chemotherapy, and they got some really amazing results. The problem is the systemic delivery has an added toxicity because CD40 is great for activating the immune response, but if you're giving it systemically, then you're going everywhere, right? And so you have this off-target problem. So you need to be able to put it at the tumor site. That's where that's the difference. And there's a lot of these immunotherapy drugs that are really can they work systemically? Yes, but are they more powerful in the tumor? Most of them are more powerful in the tumor. I mean, that's where you need to change the environment. So you'd rather put it more there. You need it from the inside out instead of the outside in. So that's it's a very very amazing CD40. And
a colleague of mine who I respect immensely, I don't think you've had a chance to meet her. I'd love to connect you with her. She's a breast surgeon, but she actually said, don't focus on the tumor, focus on the root causes. Now, I would say, well, there's some truth to that and there's some not truth to that, because when patients come to us with stage 3, stage 4 cancer, or hopefully stage 1, stage 2, where it makes the immune system's job much easier, there's a big fire.
Yeah.
And if you just say, well, let's go looking for the faulty wires that caused the fire, the house is going to burn down.
Exactly. Yeah. That's the same thing with cancer. I mean, you can't expect to go and fix that wire problem and then you're going to extinguish the whole fire. No, it's a whole other situation. I mean, cancer, once it's kind of taken over, I mean, there is maybe the root cause, but you really have to address the overall picture and what's going on. So yeah.
But the big advantage here, the big benefit, is because you're avoiding that systemic tumor approach. You're going to the tumor to activate the immune system, harness it, and we'll talk about how that occurs in a second. But then that gets transferred systemically.
Yeah.
So it's a much safer, if you said, avoiding those off-target toxicities.
Yeah. The thing is that you're affecting those immune cells that are in that environment around the cancer. That's what you want to affect. You don't want to affect immune cells that are elsewhere, that are near normal cells. Right. You want to affect the ones that are around the cancer. That's the ones that you want to change, and that's why you have to put the drugs at the cancer site.
So basically they started to discover, because actually the first phase 1 trial in 2008 was published, following his work, and they found actually some regression of tumors.
Yeah.
But as you mentioned, the systemic toxicities were just too great.
Yeah. The problem is that when you deliver these drugs intravenously, huge amounts going to hit other areas, particularly a lot of it goes in the liver. And then, that will cause the immune system to want to attack the liver. You get this a real problem with autoimmune hepatitis, I think, is a big issue with CD40. Yeah. And so, that's why you need to be specific in your area. You need to try to get the immune system to attack the cancer, not all over the body.
So then they started, as we go through the 2000 teens, if you will, they recognized the challenge of the systemic delivery. And so they thought, well, you know what, let's try to provide a better binding molecule and thus be able to reduce the dose, but then still give it systemically IV.
Right, yeah.
And they ended up with the same problem.
Yeah, they try to get it more specific, try to get it to go more to the tumor site. And that's a reasonable consideration. But again, the thing is that we can put a needle in tumor. Yeah. We do this for biopsy, so certainly we can inject the medications in there. So we might as well just do it that way. That's just much simpler than try to figure out a way to hone it in. That's much more complicated and doesn't work as well.
So what they did is 2017, 2018, that's where then this concept of, okay, maybe it's not that we need a better binding and lower dose, we just need to change where we deliver it.
Yeah.
So 2017, 2018, that's really where the paradigm shift happened. There was actually a publication, again, check out the show notes, you see it there. When did the Williams Cancer Institute start bringing this into the clinical fold for patients?
Yeah, that's a good question. I mean, I'd probably say it's been at least four years, maybe it could be 5 years. We had looked at it, we wanted to use it, we were using a bunch of other agents, and then once that one kind of came on board, that was a game changer for us. We particularly cancers that we were not seeing great responses in, like pancreatic cancer, respond very well to CD40. I mean, it really turned things around a lot, and so it really found that ended up being the real key component.
So, if you got stranded on a remote desert island,
Yeah.
would this be one of the three that you would take with you?
This would be the CD40 is your number one. Yeah. So, I mean,
and like you said, it's a part of the ongoing phase 2 SYNC-T trial.
yeah. So obviously we have the combination with the other drugs, but CD40 certainly being the key base on that.
So basically, then when this really started to hit phase 1, 2019, 2022, that's basically about the same time that was being incorporated into the protocol or the treatment strategy.
Yeah.
Better statement there, I think, at the Williams Cancer Institute.
Yeah, because so we when we designed our SYNC-T drug, we looked at the ones like what are the agents that we thought that were really good, and we had various ones that we were looking at, but yeah, at that point CD40 with so yeah, so I'm thinking is that maybe it was even, gosh, it could have been longer. I'm trying to think how many years ago that was when we were like going through that process of deciding that was the drug that we wanted to use, but we definitely were seeing that seemed to be the one. I mean, playing around with others, we tried, like, you've got the costimulatory ones, you've got OX40, you got 4-1BB, things like that. And you got like, CTLA4 is always it's a pretty good base as well. I mean, CTLA4, it's probably number 2 to CD40, I would say. But you have to have the two together. I mean, it's the thing is you need it all together. It's like you can't have just one part of it.
And we'll touch on that at the end here. So basically, looking at CD4 agonism, it's really working on dendritic cell activation. It's working on T cells. It's working on B cells. It's working on macrophage activation, particularly M1 polarization. Because I think a lot of people get stuck, Jason, into this mindset of the magic bullet theory. One drug to do one thing, but CD40, it's like a pebble in a pool of water early in the morning, rippling through the immune system.
But there's no one drug, and you got to have that concert of things going on. The immune system to get the appropriate signal. It's not going to be just it's not going to be just PD-1. It's not going to be just CTLA-4. I mean, even CD40 by itself, not quite enough. You need all of these things working in concert together, and the immune system sees it that way. It's a code. It's I mean, that's like if like a safe. I mean, if you won't open it with one number, right? You got to have all of them all together in the right sequence.
So you're describing what you're doing is conducting a symphony with these different therapeutics that are working in the immune system. So I guess we can call you Dr. Williams. Obviously we do, but it's Maestro Williams, right? Because you're conducting a symphony with the immune system.
It is like an art to it, and and the thing is that it's interesting to start experiencing seeing in human patients, because like you always had you had the mice and you had the individual stuff and you try to put that together, but then as you start seeing in the humans, and then you start seeing all the different things kind of working together and start getting a feel for it, it really that changed things for us.
Yeah. So people go, well, why does this not work on everybody? What we're starting to understand is obviously cancer is not a solid ball of cells. There's actually this tumor microenvironment. There's different components within it. But we'll talk about it because in this study what they found is there are these substances called tertiary lymphoid structures, which are kind of ectopic lymph nodes. And what these are doing is it's basically setting the stage for a training camp right nearby the tumor for these T cells to be primed. And this is what is really eliciting this systemic immune response in a predictable manner. Yeah. And CD40 in many ways is driving this to a degree, and that's what this study showed.
These tertiary lymphoid structures are kind of like your military base. I mean, if you're going to be attacking an area, you want to have your supplies and all your stuff close by, and that's why these tertiary lymphoid structures become sort of that where the immune cells can gather and sort of unite to try to fight the cancer. So when you get that.
But you mentioned the combination, because one of the things that the conclusion of this study they mentioned was they said, well, now what we need to do is to figure out what combination of therapies works with. And that's where, it's like, well, sorry, you've already figured that out.
There's we have certain regimens, certain cancer types. We say, okay, look, because again, like in the perfect world, what would you do? You would start with one set of drugs, and you would start priming that immune response, and that would probably include CD40 and CpG and CTLA4 for sure, coming in there. And then as the immune response is developing, then you would want to try to push and recruit that immune response. So then you start looking at like co-stimulatory things. So then you got like 4-1BB and OX40, things like that. And then you could arguably, there's some cytokines that you could use as well. There's various ways that you could try to push that response. And then of course, like, the other side is you got these breaks, where the cancer is going to try to start shutting off the immune responses, with the PD-1, the LAG-3, there's ICOS, there's VISTA, there's TIM-3, there's all these off switches so then it's going to start hitting those. And so, in a perfect world, you would adjust and try to do it. So, we have a base that we know for certain cancers it works and it just carries through. Right. Other cancers are more complicated. And other cancers, you need to be able to be adaptive and say, okay, we're going to start with this, we're going to change this, we pivot, and now we got we're going to start loading heavy. And as you get pushing the immune response going, you got to get heavy on all the checkpoint blockade. You got to take all that down, because otherwise the cancer's going to shut it off.
So it's complex.
Yeah.
Now, one therapy that we do that they didn't have in this study, obviously, they just injected intratumoral CD40, is PEF, and PEF generates tertiary lymphoid structures.
Yeah. So obviously you got the immune stimulation of PEF, you get the tumor killing, and it just basically functions like an immunotherapy agent of itself, even though it's a procedure device, and killing a tumor with electrical shock, and that. But it's amazing how that creates that particular immune stimulation. So it's an added bonus. Can you achieve it without it? Yes. Okay, you can certainly do it without, but adding it to it usually gives you some benefit.
Yeah. So basically, the issue as you described was the systemic toxicity, the off-target toxicity. You mentioned the hepatotoxicity really being driven by the cytokine release syndrome, but also really bad thrombocytopenia. So the challenge that they had was this: we've got a therapy that seems to work.
Yeah.
So Swiss Army knife. Yet the toxicity is so great that they couldn't figure out what to do. It took some time, but you were already in the process of figuring it out, because going back to your residency and fellowship, you knew the tumor was the means to activate the immune system.
Yeah.
Or at least that process was beginning to percolate.
Yeah, I mean, it's like you imagine it's like a war going on there, and there you got like your enemy is located there. Like, you need to go where the enemy's at, right? I mean, that makes the most sense. I mean, where the highest concentration of the enemy is where you should focus your attack, and that's how it should be in cancer.
Because that tumor burden, that plays a big role, right? In terms of treatment efficacy, activation of the immune system. Because if you have to recognize the fire in front of you, the emergent issue. We can focus on the root causes simultaneously, but you said with that tumor burden right there, you got to go get it.
Yeah.
You got to do something about it.
Yeah, I mean, basically, what it seems to be is that, what I can say is that whoever controls the immune system being the master constructor and architect of the body, controls the body.
Yeah.
And so when the immune system's working with the body, that's one thing. If cancer, though, hijacks it, and it starts taking over, now it controls the immune system, now it's working with the cancer, and that's what cancer does. I mean, it has to basically convince your immune system to work with it, and so that's really it's a very, very sneaky how cancer does that, but it understands it.
So cancer will recruit the immune system to itself. It'll then turn the immune system on the immune system to protect it.
It will start getting the immune system to work for it, because it really, cancer cannot spread and do things alone. It has to have help, and then the immune system is what helps it. And so for a cancer to go to other places, it's not just the fact that the cancer just lodges and ends up there. Maybe that can happen, right? But usually the immune system has to have helped it to get in there. And so, that's where that was the interesting thing. And to me, when I saw this in the research, like, so at Case Western did special microscope, and they were trying to look at like cell migration and stuff, and I can just remember I wasn't involved directly in the study, but I was involved with these like graduate students and researchers, and they said, we're going to tell you something really interesting. We see this breast cancer, but what we're seeing is that when it goes to the bone, the immune cells are going to the bone first, and they're normal, and they're prepping the bone, and then the cancer comes behind it. And I was like, ooh, okay, wow, that well, obviously it makes sense now, and then but I don't think people really think about that. I think people are just thinking that you got bone, you got liver, wherever cancer just lodges in there and starts growing, right? No, but that the immune system is actually prepping these areas for the cancer to go there.
It's funny you mentioned that, Jason, because there is a theory called the seed and soil theory, where in the distant metastatic sites, what happens is these, what they call them pre-metastatic niches, the soil is prepped.
Yeah.
So that then when the seed, the circulating tumor cell, arrives, and the immune system appears to be that soil preparation.
It is. Yeah.
But it's not doing it, it's being told to do it.
That's right. Yeah.
Being told to do it.
Yeah. So and these are normal cells, right? They're not cancers. They're your normal immune system, but now the cancer is controlling it. Once the cancer starts controlling your immune system, well, then you start having a problem. And that's where, when you treat cancer patients, and particularly as they start getting more advanced, you have to undo that. Now the immune system is being controlled by cancer, and you need to try to stop that signal and get it to the immune system not listen to the cancer, and to understand that it needs to be protecting the body. I mean, it's challenging, but that's kind of how it all works.
So basically what they did is they engineered this tighter binding, and they delivered it intratumorally, and they were able to show that it generated an abscopal effect. Again, local treatment, local immune activation, transferring that systemically. And people go, well, what does the Williams Cancer Institute do? We activate the immune system, but the way that transfers from just a local treatment one time to a sustained, durable systemic effect, it's that abscopal effect that most people misspell because it's a weird word, but it means away from target.
Yeah.
That's it. We activate the immune system here, away from the target, it works as well.
Yeah, it's key, and again, it makes sense. I mean, if you're going to start the immune response, you'd expect it's going to start where the cancer's at, right? And then, then it will teach the other parts of the immune cells, and then hopefully they will come in and start attacking. And that's, I mean, again, it's the flaw of cancer treatment to think that you can treat completely externally coming in. That just doesn't make any sense.
So basically what you're doing is you're taking the immune system to school. That's what you're doing. You're saying, okay, everybody sit down, chalkboard, here we go. Lesson number 1, bad guy, antigen, go get it. Now, let's bring all in the students and let's go learn and target that. Now, go out and tell all your friends about it.
Right.
And that's exactly kind of what happens with the abscopal effect. So, basically it's something first described in 1953 by Dr. R.H. Moll, actually radiation. The problem is radiation killed everything. But here, CD40 in this study, they're actually just able to show one agent injected into a tumor is able to elicit this. But do we inject one agent?
No, we don't. But you have to have multiple agents. CD40 certainly being important base, but you've got to have several things working together. And it's like baking a cake. I mean, like you come there, you just have eggs. You just have the oil, butter, or whatever. You got once you start getting all together, then you get something different, right?
Or you're lining up for a 45-yard game-winning field goal. You don't have a snapper. You don't have a holder. And you're just sitting there waiting for the ball to be snapped for you to kick the winning field goal. By the way, he was a kicker, so that's why. So then you can't make that game-winning kick because either one, it wasn't snapped, it wasn't held well, or nobody blocked.
Yeah, right, yeah.
And then you get blamed as the kicker, right?
Yeah, right.
So again, they were able to optimize the strong binding and actually lower the effect. Next slide. But what they were able to find is that basically they ended up in the mouse. They ended up with the same problem because they were delivering it initially systemically, and so they said, well, okay, we got to move to tumor. And so then they use these humanized mouse models. Now, when people think about animal models, et cetera, of course, mice. And you've used mice in a wide variety of tools. We've talked about some of those stories, how they escaped and stuff. But what's a humanized mouse model? I mean,
So of course, they have different versions, but a lot of it is particularly looking at the antibody side of that. So they're looking at mice that are expressing immune, sort of have an immune type that looks more like human. So that's the part that they're really looking at on that. So that when you're using these immunotherapies, that they would match, even though you're doing it on mice, that it's would match with the human. Right. And so and of course they have lots of different interesting stuff that they can do with these mice and we've studied mice. We cure the mice. Like we got them all figured out. Humans was what we need to be doing it in. We have the stuff we know, and that's what we're doing. And I think we're figuring out. And definitely humans are more complex than the mice. There's not even a humanized mouse that you can match with that. It's a different deal.
It gets us close.
Yes.
It gets closer. So what they found with systemic administration of CD40, monoclonal antibody, was at 0.25 milligrams per kilogram, significant liver toxicity and thrombocytopenia. So same, even lower dose, better binding. And they found, of course, an increased potency, but massive thrombocytopenia. So again, still better binding, lower dose, systemic toxicity, still the issue, until they approached the intratumoral approach, which then allowed them to not only keep the dose low, but even lower, improve the safety profile, improve the efficacy, and actually activate that immune system. So really, the answer was maybe a better binding. The answer was a better dose, but the answer here really for CD40, that Swiss Army knife, it was delivery.
Yeah. Certainly, you can do all the things to make the antibody a little more specific and bind better. But the real key thing is that putting that agent, activating that receptor at the tumor site. You can get by with some that are less, they could, as far as like they don't have as much off target effect because you're putting it at the site. You're not going to get that off target.
And what you're going to see is as a lot more people start to get the aha moments here and go, Eureka, I get it. It's important to understand there was one person that was really leading the way in that intratumoral approach. And it is this man sitting right here, Dr. Jason Williams. That's why I left leading the clinic that I was doing, because I knew that he was already introducing and using the future of cancer care today. And so what I wanted to do was join with him and be a part of what the future was and expand that to more patients. So as you start to hear more about this, remember who the quote unquote father is, and that would be Dr. Jason Williams. So basically what this is doing, Jason, is it's create, a lot of people, let me back up, a lot of people will say vaccine.
Yeah.
Right. And what happens in people's minds, they get this kind of political, argument in their head. But basically what this is generating is an autologous in situ vaccine.
Yeah. You're doing what you need to do to get the immune system to see and attack that cancer. In a situation with a virus, which is simpler, you just have the pieces and you put it in there, and that's your vaccine. But with cancer, much more complex, a lot of things going on, and so it's a little different. But it is the same concept where you're trying to get the immune system to recognize that cancer and attack it, and then you're essentially you are vaccinated at that point against that cancer, and that particular cancer, the person should be theoretically protected from that. Yeah.
And so a lot of people will say, well, I'm getting natural killer cells injected. I'm getting dendritic cells injected. But does that necessarily create a vaccine?
No, the problem is that's not a good option. I mean, it's like, sort of saying like you got a war going on there, and you're gonna throw some troops out there, and you're not even telling which side they're gonna fight for. They just gonna make their own decision. I mean, that's what you're doing. You're adding these soldiers there that are not prepped as well. I mean, some of them they try to get them, obviously to try to be, more will attack the cancer, but it doesn't have all the signals. You have to have the other signals. I think, that's a real key. Just the immune system will do it. You just need to do the right signals. You don't have to try to make more of these cells. Right. You can make the cells work and do it, and they'll take over.
What I often say, Jason, is it's like a relationship. When a relationship is working well, like here, what we're doing, there's good communication. Yeah. Now, if the communication breaks down, guess what? There's problems. Football teams, obviously I love football, so it's about to start. So, this tomorrow's first football game. So if the quarterback gets up there and he doesn't communicate effectively, if the offensive line doesn't communicate effectively, guess what? The quarterback's going to get his head taken off. Sure, yeah. So there has to be that communication, because all the pieces move together to get a first down and a touchdown. Yeah. So what you're saying is the pieces are all there. Yeah. The issue is the communication. Yeah. And cancer recognizes that. Yeah. And it recognizes that. It's interesting because people use that word vaccination, and I love looking at words. It simply means that which pertains to a cow. Yeah. Right. Yeah. So, obviously we're not talking about cows here. We're talking about, probably a better word, inoculation, right, which means immune activation. Mm-hmm. And that's really what this internal activation of the immune cells that are there that are being provided by the intratumoral approach. Yeah. It's creating a specific, personalized, precise inoculation that elicits a vaccine. Yeah. Yeah. So basically what they did in this phase 1 trial, so humans, they looked at 12 patients, and melanoma, breast cancer, and renal cell carcinoma, a mixture of them, mostly breast cancer, but they'd had prior treatments, and they had, of course, wide metastatic lesions. They received, actually, interesting enough, Jason, 4 different doses. Yeah, yeah. 4 different doses. Go ahead, next point. They looked at 0.7 milligrams, 2, 7, and 10 milligrams. Get this, they administered them every 3 weeks. Oh, yeah. How often do we typically administer? 3 weeks, yeah. Yeah. Very, very interesting, yeah. And how long have you been doing that? Yeah, for a while. Yeah, so it's, again, welcome to the party. Welcome to the party. It's great. So they found no dose-limiting toxicities. They did not reach the maximum tolerated dose. All the adverse events were only mild, grade 1, grade 2, which, interestingly enough, they had no grade 3, grade 4. This almost lines up exactly with the Synctese data update at ASCO in May. Yeah. And they had no of the thrombocytopenia, really low platelets, or the autoimmune hepatitis, so they had none of that. So basically, by delivering to the tumor, even at the high dose, the 10 milligram. Yeah, yeah, it's well tolerated. Decent enough dose, yeah. Yeah, the thing is, it's interesting because, like, initially, when I was doing the work, I was looking at the mice, the mouse studies, and I tried to think of, like, okay, how do I adjust the dosing? I know what the dose they use in mice, they did all this different stuff. So how do I figure out, well, how should I adjust that in humans? The reality is that even though the tumor is small and the mice are small, and that's a small dose, you can get activity even with very, very low doses. Of course, we found that we understand a little better now the range of dosing that you need to do. Certainly, it's on grand scale much lower than your systemic dosing. I mean, I would say on average, you'd say if this drug if you're going to use 400 milligrams, then maybe 10% would be your max dose, right? 40 milligrams. But could you get activity with 5? Could you get activity with 10? Yeah. Certainly, you can see it. I mean, you can see. I've seen it with certain cancers using multiple drugs at 1 milligram levels, and getting amazing activity with super low doses across the board. Whereas conventional medicine says, let's give a big dose, let's give it systemically, and try to get that work. So they saw no dose limiting toxicities. Again, they didn't achieve the maximum tolerated dose. very mild injection sites, no grade 3, no treatment. So conclusion, intratumoral is the way to go. Intratumoral is the way to go. Now, interestingly, then, when they looked at clinical outcomes, they were only able to, evaluate 10. So 2, whether they were lost to study or whatever, I don't know. But they found 20% of the 10, or 2, had overall response rate where they achieved complete remission.
Yeah.
So 1 was melanoma, 1 was breast cancer, again, stage 4. All they did was inject CD40.
Right, yeah.
That's it, a monoclonal antibody.
Yeah.
But of the remaining 8, 6 achieved stable disease.
Yeah.
So sometimes I think people go, well, cancer's growing rapidly, it's out of control. Sometimes the first step is actually stopping it in its track and making it stable.
Yeah.
And then now get the immune system to turn that tide.
Yeah. Yeah, because basically, when you look at aggressiveness of cancers, you have the super aggressive cancers are growing fast. The immune system is very actively helping that cancer grow.
Yeah.
And then, but as you look at the level of help of the immune system, then that changes how fast the cancer grows. If the immune system is somewhat attacking, okay, now cancer's grow slower. And so, anything that you can do to get the immune system to at least try to be after it, and maybe it's not successful at getting rid of it, that's going to start slowing it down.
Well, it reminds me of the patient today, Paul. He was asking about, well, what have we seen? He had 1 treatment, stage 4 pancreatic cancer. And he wanted to know, well, have they shrunk?
Yeah.
No, but they hadn't grown. But yet the characteristics of those tumors had changed drastically.
Right, yeah.
Which means what we expect to come
Yeah.
is they shrink.
Shrinkage, exactly.
Yeah. So what they found, though, is in those that responded, 100%, there was the abscopal effect. Now, this was a melanoma patient, 54 years old, stage 4. He had prior progression on anti-PD-1 therapy. Now, we see that, right? We see that where people progress on systemic, and then you inject it, and voila.
Yeah, that's the difference.
Multiple cutaneous, subcutaneous metastasis, 1 lesion was injected. Complete regression of injected lesion by 8 weeks. Progressive regression by week 16, complete response confirmed at week 24, with a durable response at this point of the publication, 18 months.
Yeah.
Reminds us of some of the patients we see.
Yeah.
So CD8 T cell activation, tertiary lymphoid structures that develop, cytokine profile that is favored anti-tumor rather than pro-tumor, and the development of tumor-specific T cell clones both in the tumor environment and peripherally. What's a T cell clone? I mean, in terms of, because it's not just a local immune activation, but a clone is something that it gets sent out and starts to do the same thing outside.
Yeah.
Right?
So then you get the propagation where the T cells are attacking it, but they're cloning, and you're getting more and more of them. Like it's like you got your soldiers there, and then all of a sudden imagine they can start like doubling, tripling, and you get more and more, and that's kind of what's happening with the T cell clone.
So it's kind of like a virus that's cloning itself,
Yeah.
replicating, and honestly, in a way, cancer, but here it's a good thing.
Yeah, the T cells that are attacking that particular receptor. That's the thing. Is that
that's true.
That's
true. Good point. Good point. So now, what they again found was key was the tertiary lymphoid structures, which are going to organize kind of ectopic lymph nodes. And so essentially, the way I look at it, it's kind of like a super highway with an on-off ramp right there by the tumor, so that when the tumor cells are destroyed and antigens are created, the immune system being recruited, there's an on-off ramp right there for that process to just create a nice, beautiful cocktail.
So this is one of the things that interesting. I was doing some work at Case Western, and I just happened to one of the graduate students was doing a study, and he was doing on autoimmune disease. But what he was looking at was these on and off ramps of like the immune system, because how do the immune cells get to the tumor? Or in this case, they were looking at autoimmunity, but it applies to the cancer as well. And so cancer, when it's building its area, it's making sure there's no off ramps for the immune system, right? There's no train stops for that. They wants to try to block it out, and cancer does it specifically. So that's you have to change that environment around it to try to be able to get the immune cells there.
So then let me ask a question that gets asked to us a lot. And a lot of patients, I'm sure, watching this or listening that would ask, what about where lymph nodes are actually surgically resected? You're taking out the on-off ramps right there.
Yeah.
Now, I understand it's to reduce tumor burden,
Yeah.
but what if that now tumor locally recurs? The on-off ramps have been surgically removed in a way, which compromises immune function, which is, I think, why if there's local recurrence and that lymph node dissection has been done, then basically now you have the process where it's really hard for the immune system to get there in a way.
I think, unfortunately, surgery in any cancer is probably a bad idea, and certainly removing anything is a bad idea, and removing the lymph nodes could be problematic, and so, but
Like you said, those parts were created for a reason, and they need to stay there as much as we
right.
can. As much as we can.
Yeah, better to fix them.
That's right. That's
not
right.
take them out.
That's right. Fix what's there. Heal what's there. Heal what's there. So, I mean, different areas in the tertiary lymphoid structures, they can be peritumoral, intratumoral, perivascular, adjacent. So the point is they're really key to this immune response. And I think one of the things I want you to take home here is that these therapies being combined together, as Dr. Williams has developed them and seen what's worked and gone through the science, there's an intent and purpose behind them. When you look at conventional oncology, and even when you look at a lot of what happens in integrative oncology or quote unquote natural, people are just throwing things on the wall, protocol, and hoping they work. But everything that we're doing is with great design and great purpose. As you said, it's art. The science is foundation, and people would describe medicine as an equal part of science and art. So there's the science, you have the working understanding of the science, but what you're also perfecting is the creative application of that science to be effective. And that's what you're doing.
Right,
So I love this, and we're going to put this slide on the video, so I encourage you to check this out. But basically, when we get high antigen availability and we get high T cell activation, we get antigen presentation in these tertiary lymphoid structures, and we're going to get the abscopal effect. So basically what we're doing, and you'll see this on the presentation, if you're just listening to it, I encourage you to go watch the video. You'll see this here. It's shifting it into that basically upper right, far right area where we're getting local immune activation, transferring systemically, but it's because of a clear, creative, artful application of that science. And here we're just talking about one agent, CD40, monoclonal antibody. Man, what if they had just added PEF with this? I wonder how much better it would have been. Instead of 2, it could have been 4 with complete remissions.
Yeah, a lot of stuff, obviously there's many things that could have been added to it to make it better. Unfortunately, I know how they'll do. They'll look at it and say, well, this works really well. They'll look at that one drug and they'll try to do just that. And obviously that's a nice weapon, but you need all of them together.
Yeah. And by the way, just a little bit behind the scenes, we get together as a team and we talk about patients that are doing well, patients that are not doing well, strategies to change, strategies to adjust. And then before procedure, we're actually sitting there looking at the images together and talking about how to target, how to better coordinate activity with therapies to target these tumors. So the proposed mechanism here is the initial local effects, activating via the CD40 monoclonal antibody, upregulating co-stimulatory factors, increasing antigen presentation, producing pro-inflammatory anti-tumor immune response. Remember, simply stimulating the immune system and stimulating inflammation does not equate to good or bad. It must be directed, it must be communicated, and that's what we're doing. Creation of tertiary lymphoid structures, the development and the creation of priming the T cells, and then that's then generating that systemic immune response. So you're creating a predictable, reliable, reproducible abscopal effect. And that, in a way, that's what the Williams Cancer Institute's perfected. It's taken something that people would go, wow, that's interesting. It helped there, but it doesn't help all those. You've been able to say, well, here's how we make it so that it helps all these.
You have cancers are all different. People are different. Their immune responses are different. So you come up with a strategy. You start seeing, okay, these cancers do well with this combination. These do well with this, and you start trying to put that together. And then you have others where, you have to watch and see. And then what you do is, and you try to figure out, okay, we hit it with that. What is it doing? Okay, maybe we need to consider this, maybe, and just try to make adjustments, and try, that's the only way that we can improve the therapy.
Yeah, it's like a timeout. It's like halftime.
Yeah.
It's like a courtside, timeout. It's a lot of different things.
Yeah.
So,
but in the tech industry, they have this thing they call fail fast, and it's kind of the same type of thing where it's like you're treating, and you're seeing, okay, it's not working. You don't want to just keep hitting it, because that's what happens. Normally chemotherapy, they say, well, we'll get it to you and we'll check you out in 3 months, right? No, that's too long. I mean, you want to know, and so that's what, like with the procedures, is kind of nice, because we're scanning, particularly, typically that we're doing 3-week intervals. Occasionally it's 2. Certain cases might be 4, but so you're looking each time, and you're saying, okay, is this doing something?
Yeah.
And then if I look and I'm like, because it happens commonly. I'll hit a cancer with something, and like, this cancer didn't look like it budged.
Yeah.
And I'm like, we've got to try something different.
Yeah. Well, like for example, today, what we saw? We saw a bunch of evidence in that tumor that was treated 3 weeks ago, roughly.
Yeah.
Where it looked like it was starting to develop some necrosis, liquefaction. It was just not solid.
Yeah, in the case like today, it was a good one where we're like, we know, okay, this therapy is working.
Yeah,
we're on the right track. We're going to stay with that. If something changes, we'll adjust. But that's what it is. But that's the nice thing about having this, where you're constantly looking and but also to be able to be adaptive. I mean, you're not saying we're just going to give you this one therapy and that's it, and see if it works or not.
You can't do that. And it's not protocol medicine. So what they found is direct tumor injection, localized high concentrations, minimal systemic exposure, toxicity, favorabilities of a safety profile, enhanced tertiary lymphoid structures, and only systemic effect was the robust abscopal effect. So basically, it showed the ability to generate a immune response that was precise, but against really heterogeneous antigens. So again, that concept of epitope spreading that was mentioned at the ASCO in response to the update presentation. So benefits were enhanced safety. That's always a win, because this therapy, as you've mentioned, was not tolerable from a systemic approach.
Right.
When do you think, Jason, that the research is going to start pivoting from, well, maybe we shouldn't be trying all these clinical trials in systemic. Maybe we should try some of these in the tumor.
I don't know why. It's been, a long time ago, right? I mean, it makes sense. I mean, that because that's actually what you do, or initially, like in cell, because you get all these stories and this hype that, oh, we injected this in the cancer, it kills all the cancer. And then you see that, everybody's like saying, oh, this drug kills all the cancer. Well, yeah. There's a lot of things you can inject into a cancer and kill all of it when you inject right into it. Right. That's a whole different deal than when you start looking at, in the animal. But then let's say you look at the mice. Well, again, that was the thing that I saw. In my research, we did stuff where we injected stuff in the tail vein, which would be like intravenous. Didn't work. We inject the same drug in the tumor, it works. I'm like, well, that right there shows me the difference. I mean, and so that's why I thought it was so obvious. And that was in 1994. So
a little bit while ago.
Yeah.
A little bit while ago. So then that created the autologous tumor vaccine effect, generated the tertiary lymphoid structure, again, the local immune priming, and then that generated the abscopal effect. So they're basically saying this is the framework by which this one intratumoral monoclonal antibody, CD40, activated the immune system. Not just the what, but the how it did it. Mm-hmm. And I think that's why this is so important. This was, I think, a very important article, and I think it's going to be a sentinel article moving forward in systemic versus intratumoral. But the reason why this is so important to discuss here is because your innovation, the Williams Cancer Institute, what we do, it's already led the way with this in the news real-time publication. Yeah. I mean, we've been there. Yeah. We've been you've been perfecting now, me part of it. We're working to perfect this. Yeah. And this is the future of cancer care. but we're already working on the future of the future.
Yeah. I mean, it's nice to see that other people are seeing it, and obviously they're way behind and they're not where we're at. But it gives further validation that other people are doing it, and that makes me very happy to see other people involved in it.
And you don't get jealous, right? Because welcome.
Oh yeah. The more the merrier, right? Yeah. I mean, you bring it on. We just want people to, because again, this is a team effort. We're working together to try to save cancer patients. Whoever comes up with it, whatever they come up with that we could use, it's great. And the more people that are doing the things that help us, that's just more information for us. I mean, we have great colleagues that are already working intratumoral, and we have our group. We're a very small group of us. Most of them are more in animals. Mm-hmm. And but I work very closely with those people, and I always talk with them, and they tell me what they're seeing in the animals, and I say, okay, well, we're seeing the humans, and a lot of times we have a lot of stuff that's interesting in the humans, and it's just a great process to be able to work together.
So I mean, here's the thing: they talked about challenges. They said, well, we don't know exactly. Actually, go to the next slide. The challenges that they mentioned was we don't know the right combination.
Yeah.
Okay. And what I hope that they do, if you know these authors, again, check out the show notes, reach out to them, have them contact us, have them contact Jason Williams, and he'll be able to provide some nice insight to how those, because they talk about immune checkpoints together.
Yeah.
They talk about chemotherapy in combination. They talk about radiation in combination. We work with all of those, meaning the chemotherapy and radiation being done by the local oncologist. But immune checkpoints as a part of the CD40 agonist as a combination? Oh yeah.
Yeah, I mean, there's a lot with that, and certainly we know that certain cancers, I mean, you've got certain drugs that will work really well, but like with some of the ones with the checkpoints, there may be a situation where early on in the cancer treatment you don't want to use those because that might actually give a negative signal to the immune system. And maybe the cells there are not responsive, so you need to kind of change that. Then you want to switch into those agents. So there's sometimes a timing issue. That all depends on the cancer. And we're kind of have an understanding of which ones we can't really hit with the checkpoints up front, and others you can get by with it, or works well.
Now they're moving on to phase 2.
Yeah.
They're injecting glioblastomas at the time of surgery.
Yeah.
Bladder cancer. And I thought that was interesting. We talked about this today over coffee. Prostate cancer. Yeah. And so SYNC-T trials where the result
already way more advanced than that because it's 4 agents.
I know.
So
87% response rate 1 year.
Yeah.
Metastatic castrate-resistant prostate cancer, 53% remission.
Yeah.
So, but it was a combination of 4 plus cryo, and here they're just using 1.
Yeah. We obviously when we developed the SYNC-T drug, it was very strategic. I mean, we looked and saw and had different things we tried on patients and tried to say, okay, this regimen works, and and we knew from the FDA standpoint they would allow us the 4 drugs because initially when Synchroimmune was formed and the doctors were talking with me about what drugs you want to use, and I was like, well, I've got a great one. I've got these 8 drugs, and they're like. I don't think the FDA
too much bite off.
The FDA's not going to let us do that. And so they're like, you got 4. Which ones are they? And so it was, we had some meetings and discussions and figured out, okay, if we only got 4, these are the ones that we're going with.
So it's not which 3 things if you're stuck on a desert island, is which 4?
Yeah.
Which 4? So basically, here it's okay. Now what we need to do is figure out how to create a durable response, but how to use in conjunction with intratumoral therapy. Now, there was a 2018 study here where they actually used it in humanized mouse models, combining with anti-PD-1 therapy, and they found synergistic anti-tumor effect, higher complete response rates, more durable immune memory, and enhanced tertiary lymphoid structures, which is actually what was being shown in that update on SYNC-T trial presented at American Society of Clinical Oncology in May 2025. So, so that you're showing that in real time with people with prostate cancer there, and we fully expect to see that in other cancer types.
Oh, sure, yeah.
So the broader implication, though, here is converting cold tumors hot, which ablation does that as well, creating the autologous vaccination, inoculation, immune activation, and then triggering the local treatment that transfers systemically the abscopal effect. So these are the broad immuno-oncology perspective described in the study that is being expanded and being really taken to all cancer types at the William Cancer Institute. And so safe, clinically effective, we understand the mechanistic insight, and now the therapeutic potential is alone CD40 agonism obviously is powerful, but its sweet spot is in combination. That's its sweet spot. That's its sweet spot. So this, this study, I encourage you again, read it, I say that over again, check out the show notes, because it was just published last week. Here we are, May 22nd, it's going to be August 22nd, 2025. May, I have no idea why that came from. Whew, I'm a little bit behind. And so it was just published last week. And we were in fact asked to write a comment on that study. But yet when I saw this study and when I read it, I just smiled, because it knew that when I knew Williams Cancer Institute was providing the future, and what I always tell patients is we're providing the future just today. This study is saying yes, today.
Sure, yeah.
So it affirmed that we are providing the future, and we're still way ahead of where they are, but we welcome them, congratulate them on their great research, but welcome them to the table, because the more collaborators, the better, the faster, the broader the treatment strategy that can help patients. And that's what, because this is something people don't know about you, Jason. You got a big heart.
Yeah, sure, yeah.
You got a big heart.
Yeah.
You have a lot of patients that say, hey, I need some help. And you always come through.
Try to.
You always come through. And that's something that you don't see behind the scenes. I'm going to try to get some, time from time, some shots behind the scenes, because it shows who Jason Williams are, who we are as a team, and what you really get when you come to the Williams Cancer Institute. So thank you for joining us on this podcast where we discussed a current event, a recent publication, and how that's applicable to the leadership being provided at the Williams Cancer Institute. Jason, where can the followers and listeners find out more about us?
Yeah, so certainly williamscancerinstitute.com, our website. It should have everything on there.
Now, they can also find you on X, right?
They can.
Yeah. So check out, you're going to be seeing a lot more information, a lot more commentary from Dr. Williams on X. And hopefully someday you'll be able to engage on there very, very soon in the Spaces platform with other experts in the arena.
That would be great.
And so then you can hop in there and listen in close and personal. So join us on the next podcast where we'll dive deep in with other experts, but here always bringing Jason Williams on to describe the Williams Cancer Institute and what we're doing to change cancer care today and tomorrow. Thank you for joining us. Share, like, and subscribe, please. And I encourage you to always join us on the next podcast. We will see you next time.
Thanks for joining us on this episode of the Prescribe Podcast. All references supporting this episode can be found on the prescribe.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.